what you might or carrying a little bit of extra weight in the abdomen, or congenital issues that affect what's called the hiatus, where the esophagus crosses the diaphragms into the belly. We can have kind of failure of that system, resulting in, as I said, reflux. This can cause a whole lot of issues. The most kind of, I'll say, classic explanation or description of how gastroesophageal reflux shows up is heartburn, right? These terms used to be interchangeable. Reflux and heartburn were one and the same, in the sense of this sort of burning sensation in the chest from acid irritating the esophagus. And that is one way that GERD or reflux can show up. But from my biased opinion as a pulmonologist, I would argue that the most common symptom of reflux is not heartburn, it's chronic cough or chronic throat clearing. This tendency to be clearing one's throat all the time, because as we saw in that schematic, reflux can happen just to the mid-esophagus, but oftentimes it gets all the way up to the back of the throat, where the what's called the hypopharynx, the back of the throat, has a fork in the road, splits into the windpipe and the food pipe. And if there's reflux up to the very top of that food pipe, it's bothering the windpipe, the voice box, and in kind of more severe persistent cases can actually be dripping down into the lungs, causing a variety of issues. Again, just to make sure that we're all clear on the terminology, if there's acid present, meaning we're not taking any medication to suppress acid, we might refer to this as acid reflux. But even if you've taken really powerful acid blocking medication, the reflux can still be there. The bacteria from the stomach can be sort of bombarding the lungs. The other digestive enzymes other than acid can be causing problems in the voice box and the windpipe and the lungs. So whether or not it's acid reflux or not, this can still be problematic. Again, I could talk the entire time about the relationship between reflux and lung disease, but just to highlight a couple of things. If we've got situations where we have reflux and aspiration, meaning sort of large volumes of stomach contents dripping down into the lungs, that can be really problematic. That can create interstitial lung disease or scarring in the lungs. It can cause bronchiectasis, or sort of abnormal dilation of the airways that are supposed to be smaller than they are. Or even short of that, anybody with asthma or COPD can have this triggered and set off, bronchospasm, airways that are just irritated from a little bit of that bacteria or stomach enzymes or acid getting breathed in. And it's actually a bit of a two-way street as well, in that patients with lung disease of a variety of stripes are at higher risk of reflux. And we're going to get into that in a later slide. So I mentioned the most common cause of a chronic cough is reflux, right? So people who come into our office, that's actually, if we look at nationwide data, the number one reason why people seek the attention of a physician is cough. It used to be back pain, but we took it over. I don't know if that's a good or a bad thing. The back pain and cough are kind of neck and neck for number one, and it's been cough lately. And so a cough that persists for more than 3 months that we don't have another explanation for is considered a chronic cough, and most of those cases are going to be caused by reflux. So what do we do about that? As I mentioned before, especially if we're carrying extra weight in the belly, that creates pressure, that exacerbates a natural pressure differential between the belly, which has a positive resting pressure. If we put a pressure probe into my belly right now, we would find that the pressure in there is a little higher than the ambient atmosphere, versus the chest cavity, which the pressure fluctuates as we breathe, right? So in order to move air into our lungs, we generate a vacuum by pulling down with the diaphragms and creating a negative pressure inside the chest relative to the atmosphere. So I said earlier that lower esophageal sphincter has a hard job to do. It's constantly fighting that pressure differential. And so we can help it by using a little bit of weight in the midsection and diminishing that pressure differential. The other really big issue is obstructive sleep apnea. This is a really common problem. Again, correlated with weight, but not a one-to-one relationship. There are plenty of thin people who have obstructive sleep apnea. There are plenty of overweight people who do not. Essentially, what obstructive sleep apnea is when we sleep and our body relaxes, particularly in the phase 4 of sleep, when every muscle in our body is totally relaxed, actually paralyzed. The muscles that typically keep our windpipe open can sort of flop shut. This manifests first with snoring, but if that gets bad enough and the door is totally closed, no air is going in when we're trying to breathe while we sleep. But instead, that negative intrathoracic pressure that we discussed, when the windpipe is totally closed and we're trying to breathe, we're sucking stuff from the stomach up into the back of the throat, and that makes this much, much worse. So if you snore, if you're tired during the day, if your partner tells you that you snore, if there's any suggestion that you may have sleep apnea, it's important to have it treated by, the way we treat this is typically with a device called CPAP device that keeps the windpipe open as we sleep and prevents that really extreme negative pressure in the chest, which can lead to all these other things we talked about. Going to bed on an empty stomach, elevating the head of the bed, again, having gravity be our ally a little bit rather than, if we're trying to keep things down in the stomach and we lay everything totally flat, that's a lot easier for it to reflux than if we kind of use a little bit of gravity to help us. And then I listed last there because all of these other things I would say are probably more important than the medication. The medication to diminish the acid level in the stomach can also help mitigate the risk of damage to the airways in the lungs. And I think we've already talked about those other last bullet points. Any questions? I want to make sure that this is somewhat interactive. Feel free to fire them at me if there's something.
I was just thinking in terms of the anatomy, the diaphragm, if there's any loosening around there, that could also affect it, couldn't it?
Very, very correct, right? So we call that a hiatal hernia. If that opening is a little wider than I'll say the normal anatomy, and that's a really common congenital issue to have that little so-called hiatal hernia. All of a sudden, again, that lower esophageal sphincter has no chance to kind of fight against the tide of reflux. In really severe cases, we'll look at a CAT scan of the chest and we'll see that half or 3/4 of the stomach has actually refluxed itself up into the chest and is sitting behind the heart. That's a bad situation. There's no way that medication or these other things are going to totally mitigate that in really severe cases. That can cause breathing problems, obviously, because the stomach is, when folks say, after I eat, I'm really short of breath. We look at the scan and, well, it's because 3/4 of your stomach is in your chest. In those cases, sometimes surgery is necessary to correct that. The stomach can be pulled back down. What's called a fundoplication can be done to try to fix that defect partially. But that's a very good point. Okay, yes.
Since they put me on the medication for the COPD, if I bend over to get something, I get backwash. And I don't get it any other time. So is it just a matter of, instead of bending over, just stoop down, or something that's progressively going to become worse, or something I have to worry about?
Yeah, whether or not we can blame the medication or just the COPD is tough to say. We know that regardless of the medication regimen, that reflux is much more common in folks with a COPD diagnosis than folks without it. It gets to that idea of trying to use gravity as an ally as much as possible. So as opposed to bending over like this, bending at the knees to keep things as upright as possible is what would be advisable there.
Okay.
Yeah.
Okay. Anybody else?
So, do you have any opinion on the orders with medication? So, I'm pre-transplant. I'm on a host of immunosuppressants and other things. And I take it over the counter and ask, which has to be 2 hours away from my medication. But any idea, or is it even relevant? Should I take the antacid first, then the medication, or vice versa? So I also have acid reflux.
Yeah, so there's certain medications. It's going to depend on your medication regimen. And so there's certain medications that actually require some acid in the stomach for optimal absorption. The most classic example of that is going to be thyroid supplementation. If we're taking thyroid supplementation at the same time or after the antacid, that's going to be problematic. So we usually ask that people wake up, like the first thing you do in the morning is take thyroid medication, and wait for a few hours before you take your antacid.
So that's probably a good rule of thumb. I mean,
Mhm.
minor tacrolimus might depend on the pregnancy.
Yeah. Off the top of my head, I'm not sure which of those are going to require some acid for optimal absorption, but as a general rule, it's take your other medications first and then take your antacid afterwards. Yeah, sure. Great question. And I like it if you can stump me. So again, this is, as I said, sort of the 10,000-foot overview that can hopefully spur some more good talking points like that. And this is really, to your question, to try to answer that question of where's the cause and effect relationship. The best data that we have to try to answer those questions is epidemiological, right? Looking at big groups of people and seeing what kind of trends we can see. And there's really powerful trends when we look at the COPD population as it relates to what might be called functional bowel disorders with irritable bowel syndrome, which can be either constipation or diarrhea. GERD, that's going to keep coming up. That goes hand in hand with any kind of obstructive lung disease, and dyspepsia, just kind of nausea, early satiety, or the sense that you can't eat as well as you used to, and that actually tends to be more common in women than in men with COPD. Again, I don't have an explanation as to why. We just know from survey data that that's the case.
Women complain about it.
Pardon?
Because women complain about it.
Maybe they're more forthright and kind of like admitting things. That could very well be, right? Again, the answering the question of why is always a little harder than finding a trend. You could be onto something there. Us men have to be dragged in and kicking and screaming sometimes. And as I said, the reasons or the mechanisms behind these aren't entirely understood, although we can extrapolate little bits and pieces of it to try to start to put that puzzle together. As we mentioned before, that pressure differential between the chest and the abdomen is a big piece of it, right? And so hyperinflation, which actually happens in particularly emphysema, where folks with emphysema lose what's called the elastic recoil of the chest, right? So in patients who don't have emphysema, the lung is always trying to collapse down on itself. In fact, if someone suffers a trauma, or if you get a hole poked in your chest, what happens is the lung underneath there is going to collapse down because it's kind of like a rubber balloon and it wants to collapse. But it's kept open because there's an airtight seal between the chest wall and the lung. And that interplay of the lung or the chest wall wanting to kind of spring open and the lung wanting to collapse down helps to keep all those segments of the lung nicely inflated. As emphysema progresses, a lot of those little elastic fibers are destroyed and lost. And so the lung loses some of that what we call elastic recoil. And so that interplay of the force of the chest wall wanting to pop open and the lung wanting to collapse down, the chest wall starts to win that battle. And actually, folks with bad emphysema, their chest will start to kind of get bigger, literally get bigger. The total lung capacity goes up. As that happens, that's kind of pushing down on those diaphragms a little bit. And all of a sudden, that belly pressure is going up. And so when we eat, it doesn't feel so good, or it doesn't feel natural. So that's kind of I'll say an explanation based on known physiology. Other things that we can see through kind of some pretty elegant nutritional studies look at patients with COPD versus non-COPD controls, looking at how efficiently they transport glucose from the gut into the circulation, and we find that COPD affects that. Again, by mechanisms that aren't entirely clear, as well as protein metabolism. So when we look at metabolic markers of protein metabolism, we find that it's less efficient in patients with COPD. So it's kind of a multi-hit problem, especially for folks with emphysema. We know that weight loss, unintentional weight loss, is one of the things that can happen, and it seems to be multiple reasons, right? We already kind of get full more easily and have this tendency towards nausea and reflux. And then the food that we do eat isn't processed as efficiently as it would have been if we didn't have COPD. And again, a lot of this probably goes back to that gut-lung axis issue.
Can I ask a question?
Please.
I guess I'm like kind of a newish patient. I don't really know my way around too much, but is this a question? Are these things to be dealing with your pulmonologist, or is this something that you're taking to your, your general practitioner and they're managing symptoms? Because I'm just not sure if I'm supposed to have 15 specialists or if there's a quarterback in this game.
Yeah, that's a great question, and I'd say that there's not one single answer to it. I think that communicating these things to your pulmonologist definitely is. This would absolutely be within the purview of your pulmonologist if you're having some of these issues. At their discretion, they may or may not see or hear something that says, "Wow, if we're, if let's say reflux is really, really a big problem, or we're seeing that there's a hiatal hernia on the scan," they may want to involve a gastroenterologist at some point to help with the management strategy there. But I can't give a real concise answer to that. I feel for our primary care colleagues because they have a tough job to do because kind of everything is their purview, but I'm a real strong believer that having a primary care doc who knows you well, knows kind of as much about you as possible is good. So mentioning it to them is fine, but typically you're right. It's going to be the pulmonologist that's going to manage this stuff.
And the reason for my question, I don't know if anyone else would agree with this, but it would never occur to me to tell my doctor that I was having serious diarrhea and difficulty eating, my pulmonologist. And so it wouldn't have occurred to me until now that this is linked to my lung disease. So.
Yeah, the linkage is well described. Like I said, I would not be surprised if your pulmonologist, upon hearing whatever symptoms you're having, may have some recommendations for step 1 and 2 and see if that tackles it. And if that's not doing it, then a gastroenterologist might get involved too. The army of specialists, I wish I had a fix for that, but part of it has to do with the rapidly expanding body of knowledge. The doubling time for the entire body of medical knowledge is now less than 10 years. It's like a few years. Whereas if we look at that trend going back 100 or 200 years, it used to be a lot longer than that, right? So that's part of the reason why there's so much subspecialization these days. It's good. What else? Questions or interjections?
Does it get worse?
Does what get worse?
So you have asthma. So I've been through numerous swallow tests with drinking my share of
Barium, yeah.
white gel. And the result has been that my acid reflux is, they kind of give a measure almost. It's like right here. So it's not enough to keep me from getting listed when that comes.
Yeah.
The transplant. But does that get worse? I mean, or is that even something that they can be tracked?
Yeah, I mean, as a general rule, every day we get a day older and our bodies don't get healthier with time, and so sure, things can get weaker over time. I would say that, going back to what we talked about before, making sure to maintain a healthy weight and waist circumference is probably the thing that we can most do to mitigate problems there. Taking an antacid medication mitigates the risk of esophageal cancer to a certain degree. What else can I say about that? And can it be monitored? A few different ways that can happen. Obviously having an esophagram twice a year or something like that isn't real pleasant, but it can give us an idea of are we seeing additional complications like an esophageal stricture developing, or that barium getting higher up in the chest. Or the development of a hiatal hernia getting worse. All of these things can change over time, sort of regardless of your course of action. And then just monitoring the symptoms, right? So frequent throat clearing or waking up with this kind of sensation of something in the back of the throat. All of those would be, I'll say, clues as to it getting worse, but it's not necessarily a progressive thing unto itself, if that makes sense. All right. Okay, now another huge topic that we're really essentially going to scratch the surface on, that I'm going to try to hit the most high yield bullet points for everybody in the room, has to do with the fact that nothing in life and certainly nothing in the pharmacy is either purely good or purely evil, right? Every medication in the pharmacy has a dark side to it, right? And maybe arguably, the biggest challenge in practicing internal medicine is balancing the known risk or the known downside of the medication with our expected clinical benefit from that, right? And COPD and ILD medications are no exception, you know. So some of the ones that are, I imagine the majority of people in this room might be taking include inhaled steroids. You know, the vast majority, certainly asthma patients are almost all going to be on an inhaled steroid, and a lot of COPD patients are going to be on an inhaled steroid. And the big risk with this that I guess we can call kind of a GI side effect is something called thrush, or a yeast infection in the back of the throat that can sometimes also extend down into the esophagus. The most important thing to do to mitigate this risk is to rinse our mouth and our throat out after we take the inhaled steroid. Hopefully anybody on an inhaled steroid in the room has been counseled on that. But after you take your Brio or your Trelegy or, the list goes on and on, what you're going to do is rinse your mouth out and gargle with some water and spit it out, so that we're rinsing that residual steroid that's kind of in the back of the throat out, so that we're getting the benefit that we want for it being in the lung, and not, exposing ourselves to the risk of thrush. And then again, epidemiologically, the signal is very kind of faint. This idea of GI bleeds. One study I saw that suggests that people on inhaled steroids might be at a slightly higher risk of gastrointestinal bleeding, although that we did not see this risk if the person was using a spacer. That's for like metered dose inhalers, like Symbicort or Breztri, the powdered medications that don't really come with a spacer. And so that's the inhaled steroids, that side of things. Long-acting bronchodilators, so those are going to be your long-acting beta agonists and your long-acting muscarinic antagonists, as a rule can create dry mouth, and as a result, some difficulty with swallowing, which again puts us at some risk of aspiration. And then anybody, this is a drug that might not be as familiar to everyone in the room, but roflumilast, which is called Daliresp, is a medication for patients with COPD who frequently exacerbate, meaning, gosh, I wound up in the hospital, 2 times in the last 6 months and keep getting put on steroids, and I want to get off the steroids. This medication can be helpful. And I find that the perfect patient for this is someone who has some constipation at baseline, because it's going to give you loose bowel movement. So if somebody says, wow, I could use some help having a bowel movement because I'm already constipated, Daliresp is for you. If you're already having some diarrhea, we're going to have to tread lightly, and sort of be aware that this thing almost universally is going to increase the frequency and the looseness of the stools, as well as just sort of having an upset stomach, kind of usually hand in hand. If it doesn't give you much diarrhea, it's not going to give you the other GI side effects. Typically, if it's causing diarrhea, it can cause these other things too. And then, of course, maybe no drug in our arsenal typifies the dark side of medications more than good old prednisone or the other systemic steroids. I like to use the analogy of prednisone or Solumedrol as a fire hose, right? We would not want someone coming into our house if everything was hunky-dory and spraying everything with a fire hose. That's prednisone. But if the house is on fire, you need the fire hose, right? And so as many of you are very well aware, when there's a situation where there's a flare-up of COPD or asthma and you can't breathe, we need the fire hose. The house is on fire. We need to be able to breathe right now. But there's a lot of side effects with systemic steroids. Specific to the gastrointestinal system, increased appetite, which again, in some folks is a welcome thing, as we discussed earlier. A lot of folks with COPD already have a little issue with not having a very good appetite, so that can be somewhat welcome for some. Whereas people with, for example, diabetes who are a little overweight, it's not going to be a good thing because it's going to increase the blood sugar and make you eat more and those kinds of things. And then especially if we're taking systemic steroids for any lengthy period of time, or we're having to go on them over and over and over again, this puts us at some, considerably increased risk of ulcers in the stomach and GI bleeds, as well as of course, a variety of different infections, including in the GI tract.
Doctor,
Yes.
is there a possibility that a long-term use of steroids, I'm looking at the thrush, in particular, can affect the eustachian tubes or actually the inner ear canals?
You're talking about inhaled steroids? Not to my knowledge, but conceivably so. You know, in terms of, you're talking about just having an increased propensity to having blockages in the eustachian tubes, or
Yeah.
itching, you said?
Itching, deep itching in the ears.
Yeah, I'll say I don't know. That's not something that's come up much in my practice or anything I've heard about, but I don't know. I'll be totally honest with you. As we think about that conceptually, I would think it would tend to help keep eustachian tubes a little more patent. You know, people who are prone to having their ears pop or the eustachian tubes plugging up, just kind of reducing the amount of inflammation where the eustachian tubes drain in, which inhaled steroids could do. It might help with that, but itching, I don't know about that. Maybe worth looking into.
Doctor,
Yes.
I'm taking a new drug, there.
Ohtuvayre. Yeah.
Ohtuvayre. Yeah, and it's wonderful.
I'm happy to hear that.
Yeah.
Yeah, so actually, that's one of the systemic COPD medications. It's the newest one we have, and one of the big benefits over, for example, Daliresp, is that it really doesn't have much in the way of gastrointestinal side effects. It works through a totally different mechanism to help open up those airways. So I didn't mention it here. I almost put a bullet point to say, hey, this is a new one that if you've had a lot of these side effects with others, it doesn't have many GI side effects reported. With a new drug, though, the caveat we always put is we might just not know about it yet. You know, I don't mean to be pessimistic, but you don't have to practice medicine for a real long time to become less enthusiastic about being an early adopter of brand new drugs, because sometimes that happens where the next greatest thing since sliced bread comes out and we find out a year later that it's got some side effect that we didn't realize until we gave it to a lot of them. But Ohtuvayre seems to be a really excellent addition to our
I
arsenal.
have 16 steps to my condo, and I used to be at the top. I'd be gasping, and now I'm not.
Now you're getting up there.
Yeah.
I'm happy to hear that. That's great.
So first it's good.
I have a question. Doctor, thank you for being here.
Sure.
I have on these three fingers on the side, one day I thought, what is my fingernail? I'm right-handed, and it's blood. I squeeze and blood comes to the side of my finger. And this has been going on now for a good month. And I've asked some doctors, but they're not sure. They've never seen it before. And you can see it's blood.
Yeah,
And I just wondered if it had to do with some type of a blockage or something. It could be stemming from my bronchiectasis.
that's a tough
I just
one.
want
Yeah.
your opinion. I'm not saying, and maybe there was someone else in the room that had seen this.
Yeah. The first few things that come to mind would be if you've been on systemic steroids for any length of time recently, that could certainly put you at risk of kind of spontaneous skin tears, even at the cuticle there, which is what that sounds like. Or poor nutritional status would be the other thing I would worry about for someone with bronchiectasis, right? Where kind of wound healing can be impaired. And one thing that I think we don't appreciate until we see, enough of the ways that things can go wrong is the fact that our blood clotting system is always at work in our body, right? And tipping that balance in one direction or the other can cause some spontaneous bleeding. And again, I'd be interested to know what like your coagulation studies look like and what your total protein looks like, because nutritional status can play a role there. That's my best guess without fully examining you or looking at those kinds of things.
Okay, well.
And maybe when we're done, I can take a look. Okay, yeah, for sure. All right, what else? So the next general domain of medications that, you know, I know there's at least a handful of people in the room who have interstitial lung disease, which is a broad category, but we sort of lump them together because there's a lot of overlap in our toolbox, regardless of what the specific diagnosis of interstitial lung disease might be. And I tend to, again, lump these into two main categories of what are called our antifibrotic medications, which are Ofev and Esbriet. And these are notorious for their gastrointestinal side effects. You know, it's interesting, both of these drugs came out about, I think, 11 years ago or so, in 2014, if memory serves. And prior to that, we had nothing for IPF, or Idiopathic Pulmonary Fibrosis, and its cousins. And so it was very exciting that both these drugs came out within months of each other, so that we finally had something that we could offer to patients with this diagnosis to help slow the progression and occasionally halt the progression. But the downside of all of these, you know, it's I feel badly for the salesman for these drugs, because it's like these drugs, you know, collectively are not going to cure you. They're only going to slow down your decline. They're really expensive, and they're almost guaranteed to make you feel sick. So it's like, you know, on the one hand, it's nice to have something, but the other hand, I think there needs to be always full transparency when we're talking about going on these drugs, because occasionally we can see some subtle signs on a CAT scan that maybe have been stable for a number of years. And we say, well, if you've got some scarring on the lungs, it doesn't appear to be rapidly progressive. Do we really want to put you on a drug that we know is almost certain? I think it's something like 85% of people who go on these drugs are going to have some gastrointestinal symptoms, like diarrhea, nausea, vomiting, changes in their stools. Occasionally there can be liver dysfunction associated with them. And so that decision, I think that's one of those really important moments where the physician and the patient need to make sure that they're hearing each other really well and understanding, again, that risk versus benefit analysis. In some cases, it's very straightforward. If we see, wow, this is rapidly progressing IPF, we really got to try to put the brakes on it. So just be advised that it's likely you're going to have diarrhea. My practice is typically to say, you know, to start with Ofev, because it has a little bit less of the other side effect that is photosensitivity or sensitivity to the sun, especially living here in Florida. But if there's a lot of gastrointestinal, we lost the slide. If there's a lot of gastrointestinal side effects from one of them, then we'll try the other. And sometimes patients will tolerate one but not the other, or vice versa. And so it's nice that we have these two drugs, but they do have side effects. Yes.
I'm using Vertigo. And I've been lucky, I have not had some of the side effects that have it. I do have a monthly blood work for the liver.
Yep.
Some things can happen, but otherwise, a little bit of a poor appetite, or once I start to eat, I go, oh, I'm not interested in eating.
Yeah.
I haven't lost any weight.
Well, I was going to say, I don't know if that's a good thing or not, from the way you said it. But yeah, you know, I'm of the opinion when I'm counseling patients that we sort of hope for the best but plan for the worst. I want you aware that these things can happen, but we don't know until we try. And I'm glad to hear that you're tolerating it so well, and that's always a good thing.
If you're not seeing any progression in your immune system, and the doctor wants to put you on that, and you don't have a lot of, and you have a lot of chronic gastrointestinal issues, why would a doctor kind of lean towards the opposite? And you kind of, like, that was my issue with my doctor. I was like, no, I'm not taking that. My rheumatologist said absolutely not. Why would we put you on that? Because I'm looking at you as a whole. You don't have any fat content. You have nothing in storage to lose. Like, if I was to start taking that, I have a lot of side effects. I have a lot of meds. So that's not something you need to put me on.
Okay.
So I kind of lean a little tough. And so I kind of struggle with that.
Yeah. I hear you. I think you hit the nail on the head when we say we really need to look at the whole picture.
Yeah.
And we have to have respect for the potential side effects of these drugs. You know, you could be one of the lucky ones, and you take it, you say, what's the big deal? Why were we all scared of this drug? I don't notice anything. And now I've got this, this brake pedal for the pulmonary fibrosis. Where these drugs are most validated is in idiopathic pulmonary fibrosis. That's been studied in some other conditions, but particularly if we've got low weight concerns or a lot of esophageal concerns, right? That's where we want to be really, really cautious. So I can't speak to the mindset of the doc who wanted to prescribe it to you. If I'm going to speculate, my guess is looking over years of CAT scans. If we go, one of the things that can happen is, let's say you've been followed with CAT scans for say 6 or 7 years. Each individual increment, say, from 2017 to 2018, there was no big change, et cetera, et cetera. But if we get to 2025 and we go all the way back to 2017 and we compare them, we say it's been slowly progressing. Now that we have that long, it's kind of like the story of the frog in the pot of the boiling water. Everybody know this one, right? It's sounds kind of sadistic or cruel to an animal, but the idea being that if a frog is in a pot of water that's very slowly increasing in temperature, it won't jump out even until it's like boiled to death. Versus if a frog touches a boiling pot of water right away, it's going to jump out and scramble. But that slow progression sometimes is hard to notice. That's my best guess. But again, I can't speak to what was in someone else's mind. But I think you make a really, really good point, which is to say we need to look at the big picture. And again, a middle ground would be to say, let's get a sample pack of the medication so that you're not out, having to pay a copay on a pretty expensive medication, and see how do you tolerate it. And if you're sick to your stomach within a few days, we say, okay, I tried it. I know that's not going to be good for me. But if you're in the lucky cohort, I'll say, that says, what's the big deal? This is not affecting me in any negative way at all, then it was worth a try.
So does the pulmonologist take a look and say, hey, how are your gastrointestinal issues?
Yeah, that should be. I would say that's part of the consideration, right? I think the kind of the first duty of any physician is to not hurt their patient, right? I harp on that with my trainees all the time. It sounds almost silly to say out loud because it seems so obvious on the surface, but when we start to gain respect for the potential downsides of everything that we can do, whether it's a medication, a diagnostic test, or a surgical procedure, all of those things carry risk, and we need to be confident that our prescription, the reasonable expectation of benefit outweighs that known risk, right? So,
I'm a guinea pig.
Nope. Well, there are scenarios where we don't have a lot of data to guide us. Let me put it that way, right? So there are some, and now we're getting a little off track. That's okay. There are certain scenarios where we have a robust body of good prospective clinical trial data to guide decisions or give us answers to specific clinical questions. I would say that accounts for 5 to 10% of medical practice. And the other 90 to 95% is we have some data, or we have anecdotal information, or we understand physiology and pharmacology. We're going to extrapolate that to this individual and make the best decision we can. Because there are, as we've already seen today, there are so many specific clinical questions that don't have, a good prospective, double-blind and randomized clinical trial to answer the question of, for example, is there eustachian issues associated with inhaled steroids? Nobody's ever studied that, right? And so the questions are kind of infinite that we're going to face, whereas the medical lexicon, even though it's expanding rapidly, only answers a small portion of those questions. I don't mean to dodge the question of are you a guinea pig, but occasionally we have to make the best decision we can with relatively limited guidance from the medical literature.
I'd love to hear that your fellows maybe are being trained on this, but I can tell you that my earlier question about should I be speaking to my pulmonologist about some of these things arose from me never, ever being asked about my experience outside of my lungs and my breathing. And so I, as a patient, although I'm treated like a doctor way too often, I know nothing, and I'm not being triggered to answer any of these questions. I'm should my doctor know that I break out in hives once a week? You know, should the pulmonologist know that? Is that one of these medications? Is it this, is it that? I don't know who I'm supposed to be talking to about it, but if I'm not triggered with the questioning in a 15-minute appointment, we're certainly not getting to the guts of this, medications and GI side effects in the appointment.
Yeah, I wish, again, that's a really good point, and I think that there's some competing interests in a lot of the practices, most of the medical practices, be they primary care or specialty offices, which is the limited amount of time that we have, right? The demand for the service is very high, and so there's more patients in a given day. That means less time with each one. I wish I could snap my fingers and fix that problem.
I guess at the very least, side effects,
Yeah,
you know, just a quick rundown.
Yeah, there should be, you know, ideally there should be what's called a review of systems that's done either through the intake process when the medical assistant or whoever's putting you in the room is asking you, you know, have you noticed any new kind of potential side effects, anything strange going on, any GI problems? That, I mean, there should be at least what's called a rudimentary review of systems where we kind of look at things as a whole, say, is anything new happening? And then we look and say, did that start to happen when we started a new drug, et cetera? Is that a known side effect of any of the drugs that you're on that we're prescribing? You know, in defense of my colleagues practicing pulmonary medicine, to be focused on your breathing is appropriate. That's, you know, that's kind of the main event when we're talking about the lungs, and that's the thing that is usually our canary in the coal mine for progression or stability of disease. It's also most of the validated tools, whether we're talking about COPD or asthma or interstitial lung disease, are based on, you know, how short of breath are you? And so that tends to be the focus. But, you know, there's not a single set of lungs just sitting here that's not attached to the rest of the human body. So we need to be aware of these interplays. Okay, moving on. We mentioned that antifibrotics. Somebody already brought up cell cells in the audience. This is a really commonly used medication for the more sort of inflammatory forms of interstitial lung disease. In addition to a number of others, the CellCept is sort of probably our biggest workhorse in that arena. And it's, I'll say, somewhat notorious for gastrointestinal side effects. Oftentimes, the GI side effects are going to limit the dose that we can have people on. So the way we will typically start this drug is to start at a very low dose, kind of see how the patient's tolerating things. And then if they're tolerating it, we go up on the dose in, you know, 2-week or 1-month increments until we either get to that target dose that's kind of validated in the literature, or we get to the point where the patient says, I'm not feeling so good. I'm sick to my stomach. I'm having nausea. And then maybe we go back to whatever the highest dose was that they tolerated and sort of sit steady there. So that's another one that's you know, very strongly associated with a variety of gastrointestinal side effects. And then in that, and I'll put in that kind of general others category, right, where these aren't really necessarily medications that are for lung disease per se, but they're commonly used medications, are the acid blockers. So again, to make things even more complicated, we already said that these drugs can help to mitigate progression of things like interstitial lung disease and bronchiectasis. They can help to prevent exacerbations of COPD and asthma. But if we stay on them a long time, there's a small statistical increased risk of pneumonia. It's like you can't win, right? And so again, this is something that we need to look at the individual patient. Now, why would that be? Well, again, there's a very strong hypothetical case for the notion that when we diminish the amount of acid in the blood, the trade-off there is that when the stomach is highly acidic, that's going to kill most of the bacteria that would otherwise be living there. Not all of them. There's bacteria can live in a lot of different environments, but it's going to kind of open the door to a broader spectrum of different bacteria that could be hanging out in the stomach when we diminish that acid production. And so if it's a person who has really large volume reflux, or, and the classic example of that is somebody with untreated obstructive sleep apnea, where they're pulling big volumes of stomach contents up into the back of their throat every night. It's dripping straight into the lungs. those are the patients who are probably account for this epidemiologic signal of if that happens with acidified stomach contents, you're going to feel bad. You're going to be coughing like crazy, and if you have any, airway disease, that's going to potentially flare it up. But if that's more bacteria, then that might lead to what's called an aspiration pneumonia.
Can I ask a question?
One size fits all.
You're not to pulmonary hypertension yet, but I had some recent heart studies done, and in one of my test results, the radiologist said that I had pulmonary hypertension. I thought, what is that? I have no idea. Could you define it?
Sure. And again, that's two talks on its own. That's a big topic.
Okay.
I would be interested to know what study you had done, because
I think it was a CT of my heart.
Okay, so that is not a diagnostic test for pulmonary hypertension.
No, I was having it done for, to see if
For
I
other
might
reasons.
have open heart surgery or whatever.
I understand. And what I'll say to that, being diplomatic, radiologists are tasked with looking at everything in the
No,
study.
they're very good.
Yes, and so there can be some little clues on a CAT scan that could mean you have pulmonary hypertension, but as I said, a CAT scan is not a diagnostic test for pulmonary hypertension. So what I suspect they saw was one of three things: either that your main pulmonary artery was a little wider than it should be.
Okay, and it is, and they gave the dimensions that they are.
Okay, so that's probably where they got that.
As well as my aorta was enlarged.
Right. So if it's full, sometimes we can have that finding and there is no pulmonary hypertension present.
They only, I think it was 5.5, the aorta had to be 5.5 before you intervened or something like that. And mine was under that.
Okay.
But-
Right. So as I said, there's a correlation there of the pulmonary artery. And just to kind of give a little bit of an anatomic background, remember our heart has two sides to it. The left side is what's pumping that oxygen-rich blood to the body. And you can feel the pulse from the left side of the heart right there. The right side of the heart is what's taking this blue blood that's had the oxygen extracted from it by my hand and going back to the right side of the heart to pump it to the lungs to pick the oxygen up. And then the cycle repeats itself. The right side of the heart typically has one of the easiest jobs in the human body, which is to pump blood from here to here into an intermittent vacuum. So it's kind of just pushing blood downhill into that negative pressure space, and it doesn't have to pump it very far into a big vascular bed that's right next to it. You compare that to what the left side of the heart has to do, which is like to pump blood to my toe or up into my skull, or if we're doing something that requires a lot of like heavy lifting to pump blood into those muscles that are flexing. The left side of the heart has a lot harder job to do. We can measure blood pressure on the left side of the heart very easily. You put a blood pressure cuff on you, and we can find out what's the pressure in those arteries. Measuring the pressure from the right side of the heart is a lot harder, right? Because it's all encased into your chest. So we can get clues from it from, for example, a CAT scan. We can get strong suggestion of it from an echocardiogram.
I had that too.
Okay, and so hopefully what they would have done is Doppler studies of how much blood is leaking on the right side of the heart and how fast it's leaking. But the only way to really diagnose pulmonary hypertension, which means high blood pressure in the lungs or on the right side of the heart, is to do what's called a right heart catheterization.
I had that too.
You did?
I had a small stroke. I had the whole thing.
Okay.
I had a whole, but I had the CAT scan or the echo right after the stroke, small stroke. It only really affected my left eye.
And then you had a right and left sided heart cath probably?
I'm right-handed, but when I had the catheterization done, I didn't need any stents.
Right, so that's the left side of the heart, right? So a right heart catheterization is similar but different. So
I don't know. I mean, I guess I'd have to ask the cardiologist what he did.
yeah. This is a big topic, right? And then when we talk about high blood pressure in the lungs, there's 5 different types.
Okay.
The vast majority of people who have high blood pressure in the lungs have it because they have problems on the left side of the heart.
Everything is so interrelated.
Yeah, but when we talk about pulmonary hypertension medications, and I don't want to like pry or nobody has to reveal their medical history, but like what we call group 1 pulmonary hypertension is a relatively rare condition. Accounts for maybe 5% or less of all of the people with elevated pressures on the right side of the heart. For those individuals, there are specific medications. There are blood pressure medications for the lung that helps to reduce that elevated pressure there. And they, as a group, because again, there's lots of different types of those medications. As a group, though, they do create pretty high frequency of bloating, nausea, upset stomach, and in some cases, vomiting and diarrhea. So again, and that can help guide which different classes we're going to use, right? So if we look at, for example, published guidelines on how should we treat someone with pulmonary arterial hypertension, and say, well, they should be on drug class A, B, and C, right? Well, what if we know that class C has a high degree of gastrointestinal side effects and that patient starts to have those? That's where I won't use the term guinea pig, but we need to kind of individualize the medical approach so that we're, again, not doing harm. All right. Now we're getting into, I'll say, a little bit more kind of academic topics, although they're pretty interesting, and again, give us pieces of that puzzle, of that gut-lung axis. So inflammatory bowel disease, which encompasses ulcerative colitis and Crohn's disease, are at higher risk of a whole wide variety of interstitial lung diseases. This was kind of, if you look through the history of the understanding of this relationship, early on, say 15, 20 years ago, we would say that this is usually organizing pneumonia. But as we learned more and more about this, we found that there's basically every interstitial lung disease subtype in the book can be associated with these inflammatory bowel diseases. And we remember back to the very early part of the talk where we remember that embryonically, that start as the same structure, right? So if we different expressed antigens or when our immune system is looking at the gut and the lung, there's a lot of similarities. Those sort of primitive layer have a lot of the same proteins on them, such that the immune system may have some what we call cross-reactivity, right? So if we have an autoimmune condition that's affecting the gut, classically, ulcerative colitis and Crohn's, that can start to spill over into attacking the lung too. The sort of classic example that we always have to prepare our pulmonary fellows for, whether it's in practice or, I'll say this, they're more likely to see it on their board exam than they are in real life, but it's one of these classic board questions, is the patient with ulcerative colitis who has a colectomy, meaning they surgically remove the colon because that thing is so badly inflamed and it's not responding well to medications that it needs to be taken out. That patient's at high risk of then developing lung disease because, and again, the kind of, in my simplistic understanding of it, you've got all these activated autoimmune features, antibodies and cells that now, what's the next target they have? Because the colon's gone. The closest thing in the body to the colon that's left is the lung. And so that can definitely happen. Even without a colectomy, though, we can see that kind of spillover of the autoimmune condition. And as I mentioned before, basically just about every interstitial lung disease subtype, it's kind of classically going to be organizing pneumonia, but it can be any kind of interstitial lung disease that can be associated with inflammatory bowel disease. As well as pleuritis and vasculitis too. So again, it's kind of like the whole gamut of what we would call the idiopathic pneumonias, or pleuritis, meaning inflammation of the lining of the lung and the chest wall or of the blood vessels. And it's our usual suspects here when we're talking about treating these things, which is steroids and the other immunosuppressants that you see listed there that are tended to be the ones that we use for inflammatory bowel disease. All right, cystic fibrosis. I bring this up because this is maybe one of the kind of classic. This is a condition that we understand very well. Let me put it that way, right? So we understand the genetics of cystic fibrosis very elegantly. We've been putting together this puzzle for really the better part of 30 years in terms of the understanding of the genetics and everything downstream from those genetic mutations. And so we know that this, depending on the specific mutation, is going to affect the lungs almost universally to varying degrees, as well as the pancreas and the reproductive tract. So again, without getting too deep in the weeds of what this is, the CFTR gene is the cystic fibrosis transmembrane regulator. That's a chloride channel that allows for efflux of chloride ions across mucosal surfaces. What in the world does that mean? Basically, this is really important in terms of the normal composition of mucus, right? And mucus is normal. That's why, you know, the lining of our cheek all the way down into our lungs, as well as the entire lining of the gut, and the urogenital tract is called mucosa because they have these cells that produce mucus to make them sort of slippery. In cystic fibrosis, that mucus tends to be more viscous, too sticky, right? And that causes a variety of problems, including recurrent infections and cystic bronchiectasis in the lungs. That's how it got its name. Before we knew anything about the genetics, it had that name cystic fibrosis because, you know, unfortunately at autopsy, and this would typically be a child in the days before we really had any good treatments for it, the lungs were scarred and cystic appearing. Now we know a lot more about it, and the gene was named after the disease, which we've known about for hundreds of years, but only really more recently kind of understand it. So this is one of those with a lot of overlap. And again, this could be its own hour-long talk to talk about cystic fibrosis, but to be concise, fortunately, this was like one of those really awful childhood diseases that would typically prevent the person from really getting into adulthood, and that's not the case anymore. So we're having more and more adults showing up in cystic, you know, in adult pulmonary medicine clinics. So our fellows are having to learn more about this, which is a good thing. And I guess the other thing that's worth mentioning, the pancreas. For those who aren't all that medically inclined, it's kind of two organs in one. You might associate the pancreas with like diabetes, which is true, because the pancreas is an endocrine organ, meaning it produces a couple different hormones, most notably insulin. But it's also what we call an exocrine organ, meaning it produces the digestive enzymes that we use to digest our food. And so when it gets gummed up by this bad mucus from cystic fibrosis, these patients, you know, classically children, don't digest food very well. And so that, needless to say, creates a lot of different problems. And then finally, this is something that this is a slide that I just updated because I kind of misspoke on the next part, but alpha-1 antitrypsin is something that I would hope just about everybody in this room is familiar with. This is a not terribly rare disease state that happens probably in about 1 in 4,000 people in the United States. And it is basically the deficiency. This is, again, a genetically determined thing where this enzyme called alpha-1 antitrypsin, which is produced in the liver and naturally protects our lung from our own immune system. If we have a problem with that enzyme, we're at much higher risk of developing emphysema. And again, the genetics can be a little bit complicated in that there are some forms of this that are really, really severe, where people in their 30s and 40s have end-stage COPD, even if they didn't smoke, all the way up to the more, I'll say, subtle forms that just make people more susceptible to developing COPD or emphysema, particularly if they smoke. Everybody with a diagnosis of COPD should be screened for this, essentially. And then it gets a little controversial on exactly who needs treatment, but there are really good treatments available. Basically, we give you back alpha-1 antitrypsin that's derived from donor blood, and it's highly effective. Again, without getting too in the weeds here, one of the most common genetic mutations with this causes misfolding of the protein as it's being produced in the liver, and that can result in liver disease as well. So I'm gonna addend these statements. This is kind of the old thinking, which is that COPD at a young age or with minimal or no smoking history are the ones that be screened for alpha-1. We nationwide are doing a really bad job of catching this. It's estimated that about 2% of people with this condition actually have it diagnosed. And so we want to be more aggressive in screening for this. So basically everybody with COPD, it's a simple blood test, should be screened for this. And that's a relatively recent recommendation just because we've been missing too many of it. No, there's a lot of other things that say alpha. So it's alpha-1 antitrypsin, or it might say A1AT.
So who do I tell about this? My pulmonologist?
Yeah, yeah, for sure. Yeah, and maybe they've already screened you and they'll say, oh yeah, we did that before. But if they haven't, you can say, the recommendation now is for everybody with COPD, regardless of age, to be screened for this. Yeah.
I have MAC,
Um,
and that could be I read. Now,
So MAC is an interesting thing. I didn't really talk about that too much, although we certainly could have, because MAC and all of its cousins, what we refer to as the non-tuberculous mycobacteria, definitely have GI issues, typically with regard to unexplained or unintentional weight loss. These bacteria are the cousins to tuberculosis. And historically, do you remember what tuberculosis was referred to, let's say in like 19th century literature? Anybody? This is a quiz for the room. You've been quizzing me. Now I'm going to throw one out there. What did they call tuberculosis in the 1800s, 1700s? What's that?
Consumption.
Correct. Consumption. Why did they call it that? Because the person would sort of waste away, become kind of skeletal. And the non-tuberculous cousins of tuberculosis can behave like that sometimes. It's one of many topics I didn't specifically talk about today, but we could have.
but I'm losing weight, I don't know. So maybe that's why.
It could be, right? And so sometimes that's one of the things that tips us towards, a lot of times we'll just monitor that condition, because again, those medications carry a lot of side effects. But sometimes if we start to see weight loss, it'll tip us.
I don't know if you've spoken about the new medication for IPF. Have you?
Which medication are you referencing?
Normalizing.
I have not, no.
And it's just been accepted by the FDA in October.
Yeah.
And now it's actually available. And the skepticism was reluctant to speak for the fight to start the new drug.
Yeah, that's.
Now we have feeling or have had any experience with, and also in addition to a person who has a renal impairment, it's acceptable as long as your malaria filtration is above 15.
Well, yeah, that's one of those that is going to be better parsed out as this drug hits the market, because typically that kind of recommendation comes from the fact that when they design the study and they're not really totally confident in terms of how humans metabolize this drug, right? They've got a lot of preclinical data or animal data to suggest, but we are not rats or monkeys. We are similar to them, but we aren't them. And so oftentimes what will happen is, to be on the safe side, right? These drug manufacturers, A, have an ethical obligation not to put patients at undue risk, and B, they want their study to show something so that they can put that drug to market. And they will generally exclude, they're very kind of, I'll say, exclusionary in who gets in those initial, all of those phases of clinical trials, right? It may or may not be the case that you need to have a GFR greater than 30 to take the drug, but the FDA approval is going to be based on what we know, right? Which is that this prospective trial, which excluded people with a certain, below a certain eGFR, we don't know because we didn't study them. Because, again, the drug company didn't want to take the risk of doing harm and or having a null results. Could be that as we learn more about this drug, we find out, like I'll use the example of the so-called DOACs, the Eliquis and Xarelto, right? These blood thinners that have essentially replaced warfarin. That was the teaching. That was sort of the dogma for the first probably 10 years that these drugs were on the market. Don't give it to somebody with low kidney function, simply because that's how it was studied. And more recently, we found it's actually safe to use. Again, painting with broad brushstrokes here. Being an early adopter of a drug is I don't want to discourage people from being early adopters of drugs that have demonstrated safety in clinical trials, but if you're doing well on a drug with a good track record, my general practice, and some of my colleagues aren't this way, but my general practice is to take a little bit of a wait and see approach if we have a suitable alternative, right? I'll contrast it with when Ofev and Esbriet came out, which was we didn't have anything else. And so it's like we kind of have to use this drug because we have nothing else to offer for this progressive deadly disease. Now this is a potential alternative. So the patients in whom I'm going to recommend trying it are the ones who didn't tolerate Esbriet or Ofev or had some kind of reaction to it or are progressing despite it, right? I think that's going to be the bullseye population for any brand new drug. Yeah.
I want to apologize for my phone. I can't shut it off. I'm going to AT&T when I get out of here.
She has one issue.
All right. Let's see here. And that's it. That's my family is a content to each other.
I have a question about something I saw on TV this last week. For COPD, it's a shot you take once a month. You didn't have your medication?
No, so so I'm not sure exactly which one you're referencing because all of these it's one of the biologics is what you saw a commercial for. It could have been Tezspire, could have been Nucala. These medications were really developed for. Oh, I'm good. I got that one. Appreciate you. Were developed for treatment of asthma, and again, I'm presuming that this is one of the biologics, either Tezspire or Nucala, which have pursued and obtained FDA approval for COPD. These are, I like to say, kind of like space age medications, or these are a result of the molecular biology revolution of what are called monoclonal antibodies, right? So these are antibodies which are produced in a laboratory that are super specifically targeting aspects of the inflammatory cascade. What in the world does that mean? Well, when we have inflammation in parts of our body, that happens as a result of signals that cells are sending to and from each other. And asthma is kind of, I'll harp on asthma because it's maybe a more well delineated example of where we have an abnormal and exaggerated response by the immune system to things that shouldn't be triggering that response, right? So if you breathe some pollen and all of a sudden there's this flare of inflammation as if there was some overwhelming infection, the body is kind of missing the mark a little there. And so what we can do with these medications is to interrupt that signaling cascade. And in the case of both of these drugs, these are targeting what are called interleukins, which are these little signaling molecules that the body uses to say, hey, let's make the airway really inflamed because there's a thing here we don't like. We can shut that off. These were like miracle drugs in the asthma space, like absolute lifesavers. And as many people in this room are probably aware, the line between asthma and COPD is hazy and not well defined. There's a lot of patients who kind of overlap between it. And again, as these drugs were used more and more, we found that the patients who are in that overlap area, or even those who really don't have features of asthma, ascertain benefit from these things. What I'll say to their use in COPD is, like I said, with asthma, it's very straightforward. We probably should be using these drugs more than we do. One of the big barriers is cost. These tend to be very expensive as a group. And so I'd say that's the biggest barrier to entry, is a reluctance on the part of the payers, the insurers, to pay for these things. But in the COPD space, like I said, there are those two biologics that are approved that, particularly if you're not having good control with the long-acting inhalers and things like that, that is an option. Sure.
Well, I want to express my gratitude to the doctor. Thank you very much for this conference, to have the time to give us this lecture. The team of the pulmonary rehab, I really do appreciate all this, to Rescues and Values to make it possible as well. And I want everybody to know that we're doing it as a give to everybody to see if everybody can participate on our club. This is our club. As everybody can see it. You can be on the website. Just make sure that you log in. Make sure that you just sign on it. I've been doing monthly letters for everybody to download and to read on the internet. And there is other information that I'm putting up on the internet as well. And it's open for topics. Any topics that everybody or anybody wants to bring to the team, that way we can work on.
Thank you.